thank Pawan and Sanjay for constituting this topic. So I thought it was a talk that was well received, and I thought maybe this August audience also would benefit from this talk. So pre-surgical biomechanics. So again, just to recap, most important thing I want you to know in this slide is you can see the peroneus longus curving across, going on to the first rail, and the dorsum, the lie of the tendons, EDL, it's the TA first, that is tibialis anterior there, then EDL, EHL, EDL, and peroneus tertius on this side, and the peroneal curving behind the lateral malleolus, causing eversion. So now how does all of this relate? You must take it in relation with these two. Let's change. So you can see the blue hatch line. This is the axis of the subtalar joint. This is where eversion and inversion take place. So when you take it in relation with the ankle joint axis and the subtalar axis, at the level of the ankle, where does the tendon lie? The tendon lies lateral to the subtalar line, it is going to cause eversion. So you will see the EDL, and even the EHL mild, but the EDL is a significant everter. And then any tendon that lies medial to this, for example, even the Achilles tendon is an inverter. So any contracture of these tendons will cause inversion. When you take the ankle joint axis, any tendon that lies anterior to it is a dorsiflexor. Any tendon that lies posterior to it is a plantar flexor. The main plantar flexor is the Achilles tendon. The secondary plantar flexors are the long tendons to the toes and the peroneus longus and brevis. It all depends on the momentum, the long, how far away from the ankle they are inserted, the more powerful they are. So now, coming to the next slide, with all the Sharpo that we've been listening to, and even they've told us that we've been beaming this, beaming that, but why exactly are they beaming the columns? So how does the bony architecture like? So the bony architecture can be divided into a medial column and a lateral column. If you see otherwise, you can see that the lateral column is lower down. That is why Amit was telling, when you fix the lateral column, you will see one screw going down. It is nothing but the fifth eye. The lateral column lies lower down, and it is formed by the calcaneum, cuboid, and fourth and fifth metatarsals. This has a separate orientation versus the medial column, which is formed by the talus, navicular, cuneiforms, and first three rays. So these two are independent columns. The lateral column and the medial column have a common transverse tarsal joint. But this transverse tarsal joint again is a two-part joint because there is a lateral column side and there is a medial column side. The lateral column side can lock and unlock. At least bony, that is in theory at least. So if it locks, the lateral column is going to become very rigid. Whereas the medial column side does not have that locking and unlocking mechanism. So it is going to be a very pliable transverse. That is, the input on the medial side is very pliable. So that has to be stabilized again by something else. And that is why you will notice that the plantar fascia is stronger on the medial side. I'll explain to you why that is important. So again, the ankle joint can be divided into the tibiotalar joint, the subtalar joint, and the transverse tarsal joint. I told you it is of two parts, the medial side and the lateral side. So there are three main axes of mobility: dorsiflexion and plantar flexion, the inversion and eversion, and the abduction and adduction. But all of these are usually combined into the supination and pronation, just as in the hand. The great toe goes down, it is pronation. The great toe goes up, it is supination. Okay. So, human gait mechanics, as Tatte sir was speaking in the morning, humans are the only obligate bipeds in the entire animal kingdom. Every other animal is a quadruped. They only walk on two legs out of necessity at times only. Even the gorillas, chimpanzees, you see, everything is a quadruped. Humans are the only obligate bipeds. Then gait is the forward movement of the center of gravity of the body. It occurs like a controlled fall. I'm going to fall, something blocks. I'm going to fall, something blocks. And each time my pelvis is actually moving up and down like that, apart from side to side. So that is how gait occurs. And there is a rhythmical, reciprocal burst of flexor and extensor activity. So what is the difference between walking and running? Walking has two phases. The stance phase where the foot is on the ground and the swing phase where the foot is off the ground. There is a period of double limb support. You can see there is a period of double limb support where both the feet are on the ground. But in running, there is no period of double limb support. There is a period of float where both feet are off the ground. So that is the difference between walking and running. And another very important slide is what are the different types of muscle contraction? Sorry, disorientation there. Muscle contraction can be isotonic, where the length changes with force, or isometric, where the tension changes. So length changes can be concentric, where with contraction the muscle shortens, or it can be eccentric, where with contraction the muscle is lengthened, like agonist and antagonist. So there must be a balance. So it is an eccentric contraction. Isometric, it remains constant, and with time the tension in the muscle increases until it fails at a point. So how all this fits into the relationship of the foot in the stance phase? That is exactly the phase where all the forces acting on the foot cause ulcerations. So if we know what happens in the stance phase, we will be able to decipher what is happening there, and we will be able to offer surgical offloading. So during stance phase, the foot is hitting the ground and the body is then moving forward on the fixed foot. So this can be subdivided into 3 periods, or otherwise called rockers. The first is the heel strike. It starts with the heel strike. It is called the heel rocker. The foot hits the ground in the dorsiflexed position and then comes down with an eccentric contraction of the anterior muscles into a plantar flexion. So this is the heel rocker. The foot rocks on the heel. So once this phase finishes, now the tibia will start rocking across the fixed foot. So here there is an eccentric contraction of the posterior group of muscles. So when you don't have this eccentric contraction enough, what happens is this will start to rise off early. So that is what causes the equinus contracture and increase in forefoot loading. So that was what is called the short heel contact gait. So that is what happens when you don't have enough relaxation on the posterior side. So now at the end of that period, all of the kinetic movement is stored as elastic recoil of the Achilles tendon. So at the end of that phase, the heel raise starts and continues with the active contraction of the posterior group of muscles. This is called the metatarsophalangeal rocker or the propulsive phase. Here the body is pushed forward even further. So stance, it's about 60% of the gait cycle. Foot hits the ground as a pronated foot. And in the pronated foot, the medial side is, the entire midfoot is unlocked and the foot acts as a shock absorber. And then the hind foot inverts, the transverse tarsal joint locks and the foot becomes a rigid lever to push the body forward. It's actually a hard theory, and in the afternoon after a good lunch, I think I will go some coffee. I am trying to cram this into a limited time. Okay. Anyway, another important thing is when you look at the foot, What must you exactly see? All of this, if you see, just hardly takes 20 to 30 seconds in your surgical OPDs. Just look at the foot from behind. If you see the tibia is in line with the calcaneum or maybe 5 degrees off, it is okay. This way or either way. But then, if it is way off to the outside, it is a valgus, calcaneum valgus deformity. So what happens here is an overpronation. The entire foot is tilted inwards. When the hind foot is everted, the transverse tarsal joint is unlocked. And what is going to happen is the entire midfoot is going to collapse. That is when you get flat feet. And most of the problems are on the medial side of the foot. Whereas when the hind foot is inverted, the joints are locked, the foot is very stiff. It is a stiff foot that rams the ground on the lateral side. That type of pain. So that causes an ulceration on the lateral border of the foot. So again, now I spoke about a rigid lever, the foot becoming a rigid lever. So lever is nothing but a simple machine. When you put a force, it either magnifies the force or magnifies the speed. So that is one output and one input and one output. That is a simple machine. So a lever is a type of a simple machine. So here what is required is, it requires a rigid beam. The beam must be rigid and it requires a fulcrum. So from here to the load is called the load arm, and from the fulcrum to the effort is called the effort arm. Any lever, the efficiency of any lever is directly proportional to the effort arm and inversely proportional to the load arm. If the effort arm is longer, the lever is going to be more efficient. If the resistance arm is longer, it is going to be less efficient. So levers can be type 1 levers where the fulcrum is in the middle, or it can be type 2 levers where the load is in the middle. But both of these are very efficient levers because the effort arm is longer than the load arm. Here the fulcrum is in the metatarsophalangeal joint. It's just like the wheelbarrow. So that is how the entire jumping off is achieved. Whereas in type 3 levers, the effort is in the middle. So this is a very inefficient lever. This is sort of a speed multiplier. So that by very little contraction of the muscle, you can achieve a longer distance. So the foot starts as a class 1 lever and becomes a class 2 lever. So another thing is the windlass mechanism. So as I said, the lateral column has a bony locking mechanism to stabilize the arch, particularly in the terminal phase of gait, where the arch has to be very stable for the entire body load to be transmitted to the metatarsophalangeal joints. Whereas the medial side of the foot does not have any bony locking mechanism. So here it has a soft tissue stabilizing mechanism which acts like a bowstring. It's very prominent on the first, second and third rays. It is called the windlass mechanism. So whenever you have a dorsiflexion of the great toe, you will have a plantar flexion of the first toe, first ray. It's just like the bow. You pull the string and the bow will bend. So same way, the tightening of that soft tissue structures will cause the bow to bend. So this stabilizes the arch and prevents it from collapsing. So this is the windlass mechanism. But if you see on the converse, if you try to straighten the bow, the string will also become very tight. So what happens is when I am trying to straighten that arch there, the great toe will plantar flex. So this happens during stance phase. So whenever somebody puts their foot on the ground in stance phase, they are exactly trying to straighten the bow and the great toe is going to poke down into the ground. So this happens because of the way all of the muscles are inserted into the toes. They are not inserted into the MTP joints, but they actually cross the MTP joints and are inserted into the base of the proximal phalanges. So because of the way this happens, you'll notice that instead when a person with normal feet, when he is able to dorsiflex like that, a person with a stiff MTP joint will start to compensate by pronating the foot and shearing it off. They will walk like this. That means they cannot dorsiflex there. So this causes a lot of shear and you get the first metatarsal, I mean the IP joint ulcer. Yes, sir.
Sorry to disturb you. So this windlass failure is because of the muscles?
It is because of the
plantar fascia, or it is because of
muscles, plantar fascia, everything, sir. All of the soft tissue structures. That is the elasticity comes down to that level where the body weight cannot overcome that resistance. So here, the operation of choice will be to ablate the windlass mechanism. So the best way to do it is take off the insertion of all those muscles. The ultimate insertion is the base of the proximal phalanx. You cut out the base of the proximal phalanx and wound healing is achieved. A very simple operation. But provided once you've understood it, then you know exactly why we are doing it. So here, patient comes with an ulcer, we've done a Keller, healed well. But then we are all happy until he comes back with the same ulcer. Now here what went wrong was the problem. So when we took an X-ray, it found that he had earlier episodes of osteomyelitis which had destroyed his IP joint and made it unstable. So what is happening is, the residual joint fibrosis is again causing that piece to poke down. So we opened up, cleaned everything and fused the joint. So why did we fuse the joint? You must remember that I said the effort arm must be longer and you must have a rigid beam. So the IP joint became unstable and the beam became broken. So now once I have restored the rigidity, what happens is I have lengthened the effort arm. So that will lead to healing of the ulcer. So this is, if you see here, against resistance, it's easy for me to dorsiflex when I push at the tip rather than when I try to push at the base. This is simple physics. So once you understand it, just put in an IP joint screw and your Keller recurrence can be prevented. So this has led us to modify our protocol where we started fusing primarily itself. Why wait for them to get an ulcer? Once you see a dorsiflexion of the IP joint on the X-ray, primarily only we will fuse it off. So do the Keller and immediately retrograde fusion. Just put in a screw there. We are not going to take off the cartilage or anything, just stabilize the IP joint and then done with it.
So now you have modified, you are doing fixation after the Kellers.
Yeah, yes, immediately after the Kellers, only when there is an unstable cocked up toe deformity.
Okay.
Previous episodes of infection have destroyed the FHL or something and the toe is cocked up like this. Then it is better to do a fusion earlier only.
But you are not treating an infection each and every case. In some cases you must be treating.
No, we don't fuse for every case.
So you told when it is.
Only when it is cocked up or the IP joint is
You
destroyed.
started then after Kelas doing this thing.
Which one, sir?
After Kelas you say now
If
you are
it is
doing.
popped up.
If it is cocked up. If it is cocked up, yes. If the joint is not stable because of osteomyelitis or any other reason.
Flexion mechanism at that point should not be working.
Yes.
Then that is the time when you have to do this.
Yes.
Otherwise, simple Kellers is enough.
And this is also exactly the reason why we don't do a partial toe amputation. Because the windlass mechanism is still intact. And what happens is you have a smaller effort arm and that reduces the ability of the stub to dorsiflex. That will keep poking into the ground. And once you excise that stub, the ulcer will heal. So we never do a partial toe amputation, rather we would disarticulate them. This is one of the modifications. What we understood from our years of.
In weight bearing, is it better to have the metatarsal head or?
Good question.
This is about the grade toe, sir. We never leave a partial grade. There are some cases where nothing will happen. But in general, if you take it off, you can definitely prevent a stub ulcer. The most probably this person would have had an ulcer at the IP joint. They removed the toe partially. Now the ulcer will only migrate proximally. Because the intact windlass mechanism tightness is still there.
So I think what you asked was the metatarsal head Should be preserved or?
Metatarsal head must be preserved at all costs. We would, in fact, we have gone to the level of starting putting free flaps just to preserve the metatarsal head. Because morning sir showed a slide, no sir, 50%, 50%. And out of the 50% load, the first medial ray will carry 30% of the entire body weight. So it is very important to preserve the first metatarsal ray is as thick as your ulna. And it must be as thick for a reason.
So do you leave the cartilage there or do you?
Yes, we leave the cartilage.
You have
We leave the
never
cartilage, but we will immediately cover.
cover soft tissue cover?
Yes. So first metatarsal head ulcers, PL to PB, followed by Jones. This is the protocol. And fusion of the IP joint. But what happens is you usually get a slightly supinated foot and the ulcer heals, but he'll come with a transfer ulcer on the lateral side. So once you get that, is do a wheel osteotomy, raise that metatarsal up, healed, but he comes back with a ulcer on the another metatarsal. So again do a wheel osteotomy and it heals. But then it is telling you something. It is telling you that most probably the gastroc soleus is tight. So such cases, we do a gastroc soleus resection, where they have multiple metatarsal head ulcers, recurrent metatarsal head ulcers, or a very objective finding on the pedobarogram where forefoot to hindfoot pressure ratio is more than 2. These are our indications for gastroc soleus resection, or TA lengthening as whatever you are comfortable with. And once you do that, you will notice that part of the load will come to the hindfoot. The idea is to redistribute the load to the non-weight bearing area. Remember, we talked about a tight posterior side, not eccentrically contracting enough. So it is pulling the heel into dust up into the air earlier so that more amount of load is borne on the forefoot for more amount of time. That is what is happening. So now what I am doing is essentially I am making the heel stay on the ground for a longer period of time. So here peak forefoot to hindfoot pressure, previously 2.7, post-op 1.8. It's easier and objective. But the same thing, if you overdo it, then you will get a heel ulcer. Because the entire load now has come behind.
For a gastrosoleus resection,
Yes, sir.
you are doing the middle 1/3.
Yes.
Opening here.
Yes, the zone 2. Yes.
Lower is the better, middle is the better, or upper is the better?
We would do it about an inch below the gastroc insertion, sir. Too low, you risk rupture. The lower down you go, more is your release. Because the residual contracture depends on the bulk of the soleus that is available. The soleus is a conical muscle. So what happens is as you go lower down, the residual fibers are very less. So the lengthening will be more, at one point it can even rupture. So if you overdo it, you will get a heel ulcer. Then heel ulcer healing, by any flap it is easy, you will get an ulcer healed. But if you see, if you put him onto a pedocarcinoma, you will still have calcaneal gate. And unless you are going to arrest that, this ulcer is going to eat through my flap, just like termites eat through your old MRD records. So, here what we done is, because the calcaneum is all broken, we couldn't do a TA reconstruction, we fused the ankle. Here again, we learned a lesson. This was one of our earlier fixations. Now we fuse across the midfoot. Because even slight mobility at the midfoot doesn't give us load transmission to the forefoot. You must fuse up to the first rib. But if you see the pedobarogram, luckily since his midfoot was stable, you see the calcaneal gate is corrected and the load is now transferred to the first rib. And this is how the patient will keep walking. Even though he has a stiff ankle, he will compensate with his knee and hip.
Would you require special footwear after this?
Yes. This is just for the purpose of videos we have taken.
But in the pressure graph, the pressure is okay. But even then, will it require?
Yes, definitely. Madam. Yes, definitely. As long as he has no sensation, he will require footwear. But they can just get group specific footwear. Because anybody with a stiff ankle will require a posterior and anterior rocker. Instead of an insole modification, what he requires is an outsole modification. So, in patients who have an intact calcaneum, we would go ahead and do a soft tissue reconstruction by tendon transfers using the FHL. Actually, you see this is a pedobarogram of an FHL reconstruction. Here too the calcaneal gait will get corrected. We have published it on JPRAS. This is what I was talking to you. I haven't put the paper on the group. So now next is peroneal overdrive, where the first ray ulcers. So exactly because of the way peroneus longus inserts. Peroneal overdrive can be either a very powerful contraction of the peroneus longus or the failure of the peroneus longus to relax in time because of neuropathic changes. So if it doesn't relax also, there will be a very large increase in pressure under the metatarsal head, which can be treated by a peroneus longus transfer. The solution is to divide the peroneus longus, but you transfer it to prevent an inversion deformity, to retain the eversion power. So that is the idea behind the peroneus longus to brevis transfer. And this is what happens if you lose all peroneae. You lose all peroneae, the foot will go into an inverted position, the hind foot will invert, you will have a very severe lateral border ulcer. So this is typically a patient who has only the inverters working. Everters are not working absolutely. You notice the typical ulcer on the lateral midfoot.
So this case has happened after the wrong peroneal surgery?
No. This case was congenital, sir. This case was also congenital. Usually these patients are seen as meningomyelocele patients. Yes. So here the job is to reconstruct the everter. So remember the subtalar line. So you take the strong inverter from this side of the line to that side of the line. And at the same time, as we told you, the Achilles tendon is a very strong inverter. So any equinus contracture, the hind foot will go into inversion. So you must release that also. So this is a Z lengthening. So once you do that, what was this? Will become this.
When to do the split and when to do the complete transfer?
Which one, sir? Split. We prefer complete transfer. Yes.
Is there any forefoot drop is there, sir?
Yes, because the equinus contracture was this. So now if you see, she walks, even though there is a mild residual deformity, but ulcer healing is there and her gait totally changes. So even the ulcer will disappear. And she uses just normal offloading foot. Which one, sir? Yes.
So
the interference screws. Yes.
So in this case, you with the TA,
Yes, sir.
which muscle you transfer to the
The tibialis anterior will transfer to the lateral side. So yes. And for the toes,
They will act as everter.
yes, sir. Yes. For the toes, usually the problem is the loss of the intrinsics. In the morning, I told about the lumbricals and the introitiae. See, just as in the hand, the function of the introitiae is to flex the MTP joints. In the hand, the MCP joints, and straighten the IP joints. You can only have straight toes if your intrinsics are okay. Otherwise, just as in the hand, you will go for a claw deformity. So, if your intrinsics are not okay, the phalanges will not balance, everything will go for a Z collapse. If this points this way, the next will point this way, the next will point this way. So it's nothing but, it's called a Z collapse. It will just collapse like. So, it's just like the draw rein deformity of the horse, the rein that pulls the moor. So that will cause, if you see when he walks, that will again cause a severe pulling down of the neck of the horse, and that will cause the toe to dig into the ground, and a tip ulcer of the toe will come. That is because the loss of the pulp to floor contact, you will get a tip to floor contact. And this is easily remediable by a flexortinotomy. You can do with a 16 or 18 gauge needle. Some cases they come infected, we prefer to do a open debridement with a tenotomy. So similarly this case, we have done a Do you know what I mean? Strong windlass, but you must also remember that I told you there is a strong windlass mechanism on the medial side, medial 3 columns. So when you do that, sometimes you will unmask a strong windlass mechanism, because the clawed toe will keep the MTP joint extended. That is one power and Amit, but I'll explain the mechanics. So here we saw that we need a rigid beam for the foot to push this load against this fulcrum with this effort. Now what happens is, the fulcrum which is here, and the foot has to go into dorsiflexion, and if the fulcrum is broken, the fulcrum will shift to the next stable point. The next stable point is the bump on the plantar surface of the foot, and that will keep digging into the ground because the TA cannot be overcome. So this you can diagnose by the Mieri line, taking all this has been already explained. You'll see on the pedobarogram, you'll see the pressure on the midfoot. The idea is to reconstruct the Mieri line and get back that. So similarly, in partial foot amputations, you will see that there is often an ulcer at the tip of the stump. This is again because of the broken lever effect and the shortening of the effort arm. For example, if you take this is the ground reaction force acting on the foot, which must overcome the equinus contracture of the tendency of the ankle, which if it is X, you need this length of the effort arm to efficiently overcome the equinus contracture. But when you do a partial foot amputation, the effort arm shortens very much. So now this length cannot push it because simple physics tells it you cannot overcome the resistance. So the only solution will be to weaken that load by doing a gastrocnemius or TL lengthening. But then we prefer not to do that, because again what you're going to give them is a very small contact area, which in due time will start ulcerating. It is just like giving back the patient a calcaneal gate. And the idea in preventing a diabetic foot ulcer is maximizing contact surface area. So there is no point giving them a very small contact area and the patient has to hobble like that, which is very, very inefficient way to walk. Instead, you do a below-knee amputation, and if you notice this, if this patient's pant was down, nobody will even notice that he has a prosthesis. All of these concepts we have taken on to the Tamil Nadu government. This protocol has been accepted, tried, tested, it is working, and it is being established as a GO, the Padam Padagapum Thittam. And as Sir often quotes Rudolf Virchow, epidemics are social in origin, and the way to combat epidemics is not medical but political. So that is the only. He also has another very good saying, sir. Good data backed by scientific evidence finds policy approval. So when you approach somebody to get a policy approval, you must go with this. If you don't have this, don't go, he says. Okay, sir.
So you don't subscribe to TMA or?
Yes, but then half the metatarsal, 75% of the metatarsal you're going to take off and exercise.
In other words, a midfoot, so amputation is something which you don't recommend.
We don't recommend. I cannot say we don't do.
Prefer a below knee to a.
Yes, I would prefer a below knee. I would explain that to the patient. But if the patient says no, I want this only, I would give it back to him.
So metatarsal heads,
Yes, sir.
if you preserve,
It's very good for walking. It's like having the whole foot.
and you do a TA and that is okay. But if you cut the metatarsal heads, it is better to go for a below knee.
No, about 25% of the metatarsal you can remove
Okay.
and still have a acceptable length. 50%, 75% of the metatarsal you're going to take off. We think that below knee is better, at least for our patients.
If possible, would you like?
But if the patient doesn't agree, we would never. We would tell him about it. We will tell him that a Veroni is better. If he says no, at all costs, I want my foot, I will give it. Young patients, young fellows, post-traumatic injuries, Lisfranc amputation, we would still save the foot. Do a TTC nail, give him the foot, allow him to get married, then come back for the amputation. They do that because our social situation is nobody will give a girl in marriage to a guy who is already amputated. At least the guy with a partial foot, some acceptability, something is there.
If it is a non-diabetic,
Non-diabetic, so it's trauma, young trauma.
So in such cases, what are the other adjunctive procedures do you do, Madhu, to make sure that?
Sensate foot, you can do your gastroc surgery. The foot will protect itself.
Yeah.
Insensate foot,
No, I am asking in case in a traumatic link you might have to cut more than 50%. Do you think of doing the same procedures and?
yeah, we would do a gracilis, we would do a cover, then we would, if we find that, and we would cover it and leave him. If he has been able to do his dorsiflexion and move on, we will leave him alone. But if he is going down, then soft tissue procedures first, still not getting okay, TTC nail.
There is simultaneous timeline also will go. Like EHL impact in this case,
Yes, you can,
in the partial.
tibial is anterior is intact, you can leave him like that. On the lateral side, you can take one of the EHL or EDL and put it into the, but usually not necessary.
So
But if it is available, you can put it in.
I just wanted to ask you, I mean, we have had so many cases of, I mean, I have started doing that. We have had so many cases of grade 2 amputations, first ray, invariably the head is not salvageable, you have to remove the head, sesamoids and stuff like that.
So once you release that, usually it goes. But then if the head is intact, we would do a dorsiflexion osteotomy.
Yeah, head is intact is fine, but I'm asking in cases where head and sesamoids are gone.
We usually don't sling the.
One of the common cause of lingering infection in the great toe is infected flexor hallucis longus, and you remove it behind, like just open up behind the ankle, do a small tenotomy and excise from the distal end, and this lingering infection will go. So FHL remaining is one of the very serious issues.
It's not about infection, Amit. What we are talking about is basically the mechanical problems, wherein whatever you have cut.
Mechanically, as he has said, PL to PB is one.
Yeah, that's what I wanted.
Second thing is,
So I have started doing a EHL tenodesis.
I always remove the head, sesamoids and cartilage in the scalp whenever I am going to the metatarsal lamination, because they are the sites where the lingering infection will remain.
For the record, the first metatarsal head ulcers, what you are asking is just the Jones transfer.
Yeah,
Yeah.
basically. Yeah.
Without releasing the PL, the EHL is too weak.
Prefer the cartilage to be intact.
Intact, provided I can give immediate soft tissue cover.
Okay, so if I get a skin
You can
cover
get a
primary
cover.
closure, it has to be careful.
Okay,
And
you
same
can
with
get
the TMT or
No, TMT you cannot. TMT in the
just
case.
disarticulate.
Yeah, that you will definitely get a problem, sir. We don't do transfer. I mean,
Yeah.